Hi, my name is Peter Gliotto, and I'm from the Mount Sinai Visiting Doctors Program. It's my pleasure to talk to you today about home care. This presentation is a collaboration between myself and Doctors Emily Samuel and Sonika Bhatia. And the pictures were taken by Dr. Anna Blum, and all of the pictures have permission for general use by the patients or their patients' family members. I do not have any conflicts of interest to disclose. The objectives of this workshop are that by the end of this session, you should be able to define home care, describe services available to patients at home, identify patients who could benefit from different kinds of home care services, and explain reimbursement or opportunities for home care services. What is home care? Broadly defined, it's any diagnostic, therapeutic, or social support service provided in the home. And as you can see in this image from over 100 years ago, visiting nurse and other home care services have existed for quite some time and are really core to our identity as providers. Why is home care so important? There are many patients in the United States who cannot access facility-based care, either in an office or a hospital, without very taxing effort. This study from 2015, looking at a cohort of patients from 2011, estimated that there are about 2 million patients who are homebound in the United States. A more recent analysis published in 2024 estimated that the number of patients who would qualify for independence at home, which is a CMS demonstration project, which I'll talk about more later, that about 3.3 million patients would qualify for that. So there are a very large number of patients who would benefit from care being delivered outside of traditional facility-based settings. We also know society is aging and that the population of people with functional decline and high symptom burden is also growing. There's a lot of caregiver burnout in our society, and there's a growing population of patients who do not have any direct caregivers available or close family members. Also, it's important because seeing a patient in their home gives insights into the patient's lives and care in a way that really is inaccessible in other ways. This, again, is an image from Dr. Blum of one of the patients that we've taken care of in our visiting doctors program. So let's discuss a theoretical case. So Miss D is an 85-year-old woman with type 2 diabetes, hypertension, osteoarthritis of the knees and hips, who has fallen multiple times and is now missing most of her outpatient appointments because she is afraid of walking outside. Her daughter does all of her shopping and laundry, but does not live with her. On the most recent office visit, which took the patient over 30 minutes to get down the stairs for, the patient had multiple duplicate medications and some were expired. In addition, she reported significant pain and debility due to her arthritis. So does a patient like Mrs. D qualify for home health services? And if so, what can she qualify for and how can they help? So if we're looking at Medicare, Medicare pays for home benefits when the following criteria met. Patients homebound at the time of the assessment. They required a skilled care, meaning it has to be delivered by a provider as opposed to a family member or a non-skilled caregiver. The provider completes a home health certification with a face-to-face encounter documented, and that the agency that used is certified by Medicare. So who's homebound? There's two broad criteria. One is that a person, because of illness or injury, needs the aids of supportive devices such as crutches, canes, wheelchairs, and walkers, the use of special transportation, or the assistance of another person in order to leave their place of residence, or have a condition that leaving his or her home is medically contraindicated. They must also meet this criteria that there must exist a normal inability to leave home, and leaving home must require considerable and taxing effort. Okay, so basically, in our program, which is a home-based primary care program in New York City, many of our patients easily meet this because of their illness, but also because of their environment. A patient like Ms. D may have less trouble getting to doctors if she lived, say, in a ranch home or something like that. But if she lives on a fourth floor walk up, getting out of the door may be much more restrictive for her. So some examples of home health care. Nursing care is a big component, probably the largest component. Nurses can do a number of things in the home. They can monitor vital signs. They can titrate medications for symptom management or therapeutic goal, whether it be diabetes, hypertension, goal-directed medical therapy for heart failure, et cetera. Wound care, either post-op care, pressure ulcers, friction ulcers, that kind of thing. Patient and family education regarding chronic illness management, but also can include specialized services like managing home ventilators or PEG tubes, and infusion therapy. How do you make a referral to a visiting nurse agency? So visiting nurse agencies are often referred to as certified home health agencies. You would contact one of these agencies, usually to make sure that they have a care provider in that area and are on par with the patient's insurance. And when you make a referral, they may have a form or some sort of standard mechanism for it. But in general, the more specific you are, the better. Include parameters for, say, example, wound care, or how and when to contact you, for example, for high blood pressure, or what glucose level to contact the provider at. In addition to filling out a referral, Medicare requires that there's been a face-to-face encounter between the provider and the patient. It must be within 90 days prior to the start of the home care or within 30 days of after the start of the care. And it must be specific to why you're referring the patient. For example, if a patient develops a wound and you're referring for that particular issue, you need to have seen them for the wound either within 90 days prior to the referral or 30 days after. Other examples of home health care, which may be part of a general visiting nurse service or certified home health agency, include physical therapy, which can provide gait and balance training, home safety assessments, and evaluation and referrals for assistive devices and how to use them. Speech and swallow therapy, for example, after a stroke or Parkinson's disease, or people with dementia who need specific evaluation and training around safe feeding practices. Physical therapy is often bundled under a certified home health agency and is usually billed under Medicare A. They can also be under Medicare B and billed separately, and there are certain different parameters for those kinds of services. Additional services often provided by CHA or certified home health agencies, as we refer them to, as include occupational therapy, social work services, short-term home health aides. These are home health aides who provide basic custodial services to patients, and I'll talk more about that later. And some agencies may have some capacity to do limited behavioral health therapy. Does Ms. D qualify for personal care in the home? And what do we mean by that? Personal care in the home usually is funded through one of these mechanisms. One is Medicaid, and that's very common in my state of practice, New York. It varies very widely state by state, and it's often funded by a variety of different Medicaid waiver programs. It could be funded through long-term care insurance. There's often private pay options, and veterans may also have options not available to other people. Home health aides are the bedrock to keep many of our patients at home. They provide services like bathing, safe transferring, feeding, alerting providers when the patient's not themselves. They are really the connection between the patient and the outside world, and often are much more than that. As shown in this picture, many times the patient has more contact hours with a home health aide than with anyone else, even family members. And this person often becomes as close to the patient as a family member and has insights into the patient that we may not have. Many of my patients would not be at home unless they had personal care services through a home health aide, often funded either by Medicaid or privately. How about medical equipment? Medical equipment is divided into durable and non-durable types. Durable refers to things like hospital beds, which are usually semi-electric, meaning that the head and the foot go up with an electric mechanism, but the entire bed being raised or lowered depends on a crank. Wheelchairs, whether they be manual or motorized, walkers and canes, bedside commodes, patient care lifts, or also known as Hoyer lifts, oxygen therapy, different types of mattresses to help relieve pressure to either prevent or help treat bed sores. These are often paid for by Medicare and require specific justification for their use. Non-durable include things like incontinence supplies, wipes, gloves, and dressings, often not paid for by Medicare. They may be covered by the visiting nurse service or certified home health agency during an active period of care, or they may be funded by Medicaid, or the patient or the patient's family may need to pay for them. In terms of equipment orders, it's very important to have proper documentation. Often these are very extensive and specific, and it's good to consult reference manuals from CMS or other places to make sure that you're doing it correctly. It's good to use templates and sometimes requires medical certificates of medical necessity to be completed, and often needs the most recent chart notes to justify these orders. It also may require that the patient be seen within the last 6 months. What about home-based medical care, also referred to as home-based primary care? This is usually done by a physician, a nurse practitioner, or a physician assistant. Standard care for home-based primary care is for home visit providers to work as part of an interdisciplinary team, which often includes nursing and social work services, 24 access to providers through call services, and regular team meetings to review cases and discuss care. The visit really needs to be medically necessary and shouldn't be just sort of a convenience. And many providers and practices stick to the Medicare homebound rule in order to justify the care that they deliver in the home. There's growing evidence that home-based primary care improves quality and is cost-effective. The Independence at Home demonstration project by the Center for Medicare Services was a 10-year-long program that demonstrated that patients in this program had reduced Medicare expenditures of about 21%. There's been a huge growth of value-based care models, whether funded by public options or through insurance companies. Frankly, it is hard to make a home-based primary care program fiscally successful in just a fee-for-service model because it's difficult to see enough patients to justify the costs. And many programs are turning to value-based models as a way to demonstrate fiscal sustainability. Here's another picture from Dr. Blum, just giving an example of polypharmacy, as well as the types of insight you may get from seeing a patient in the home as opposed to the office. Could Misty benefit from palliative care in the home, and what do we mean by that? Home-based primary care, palliative care, refers to the following: symptom assessment, functional assessment, evaluation of the social and caregiver network, and advanced care planning. This may be part of a home-based primary care program or may be delivered mostly telephonically. There's many different models existing for home-based primary care. Other examples include home hospice, home health based palliative care, bridge programs, meaning that a person may not be quite eligible for hospice And the bridge is either to a point where they are more functional or become eligible for hospice, or they can be more consultative. What other home-based programs may be available for Ms. D? There are many, and it depends on your region and your health system. Community paramedicine is a growing type of program. This involves usually paramedics coming to the home on demand to evaluate a patient, usually for an acute issue. They can do things like certain diagnostics, like lead tracing or EKGs. They can do nebulizer treatments or IV infusions. They can give diuretics, and they can stay in the home for a brief time to see responses to these interventions. Or they can make a decision that the patient is ill enough to go to an emergency room. Um, these are sometimes associated with other larger programs or freestanding. Certain transitional care visits are often parts of many different types of home-based programs and are very valuable in terms of evaluating patients when they are home after a hospitalization or a period in subacute rehab to make sure that there are no gaps in care. Hospital at home and rehab at home are growing types of models where certain diagnoses that would be eligible for inpatient stays are diverted instead to home. So the patient may be evaluated in an ER and sent home, and their period of care is done at home, facilitated by nursing visits, provider visits, and telehealth. There are a variety of telemedicine models that provide home-based care management. There's also a number of remote monitoring programs looking at a specific parameter like blood pressure management, COPD management, or diabetes management. Infusion services, which provide ad hoc or ongoing therapies like chemotherapy in the home. And there are a variety of models of behavioral health at home, either in person or more commonly through mobile apps. Depending on your service area and local providers, there may be options for dentistry, optometry, podiatry, audiology, and some home improvement services where professionals will go into the home and install grab bars or help remove clutter or help identify fall risks and help the patient's environment be as safe as it can be. Some of these services can be one-offs paid for by insurance companies. Other ones are more fee-for-service. If you're a provider, how do you get reimbursed for providing and overseeing home care? So most doctors do not make house calls, but you can get reimbursed for care that is being provided in the home. So if you are making house calls, it's important to know how to bill them because there's a different process for billing them than office visits and slightly different reimbursements. Some of the codes are slightly higher for an equivalent office visit. Some are about on par. There are 5 codes for new visits and 4 for revisits. These were simplified about 2 years ago and meet the same standards for office visit in terms of billing either by time or by complexity. Other codes that people can bill for, even if they don't make house calls themselves, include things like home health certification or a 485 encounter. This refers to when you refer somebody to a home health agency, you can actually bill for that referral as long as you've had contact with the person or persons who are providing that care in the home and have made efforts to coordinate your efforts with their efforts. That's a one-time for each certification period. You can also bill a monthly care plan oversight for patients who are involved in certified home health agencies, as long as you've logged in a certain number of minutes discussing that case with a professional, either a nurse or physical therapist. Conversations with family members and patients themselves do not count. Transitional care management is becoming more current, and there's a number of health codes and billing codes and levels that you can use with transitional care management. This is for people who have Medicare, and it's based on time. Often it's a minimal of 20 minutes to bill at the first level. And what's nice about transitional care management is the efforts of other people in your office can count. For example, in a given month, my patient or their family members may interact with me, may interact with a nurse in my office or a social worker, or perhaps if your office has one, a pharmacist. Any one of those people can log the time that they've spent caring for the patient, and that all contributes to a monthly transitional care management tally that you can then turn into a bill if you've met certain criteria. Advanced care planning is also something you can bill for. It's time-based, and the minimum time is 15 minutes of face-to-face contact. And that's addition to, say, another service code that you are dropping that day. So let's wrap up the case of Mrs. D. So back to the case, she got referred to a nursing agency, and the nursing agency did a thorough medication reconciliation and taught a family member how to fill a pill box so that the patient can work on medication adherence, and we can monitor their progress with that. They also taught the family and the patient how to do glucose measurements, and for a period of time, they did blood pressure monitoring. In addition to the nurse, a physical therapist was involved. That person did a home safety assessment and was able to perform measurements for the correct kind of assistive devices and put it in order for that. And they were able to do some home-based exercise programs that improved proximal muscle weakness and balance training. In addition to the assistive devices, they recommended a shower chair and a raised toilet seat to help minimize risk of falls. While the patient had the agency involved, they were able to get 4 hours of personal home care services a day as the patient became stronger and these other pieces of care became in place. And a social worker also assessed the patient for making sure that there were adequate resources, and also gave the caregivers a list of resources that they can access. In terms of what the provider does, the provider can continue to home visits, and they collaborate with the team. So this is an example of Mrs. D, for example, say if she was seen by a home-based primary care program, that home-based primary care program would be continually involved and may see the patient, say, every 2 to 3 months. On average, for example, in our program, our patients on average are seen about 5 times a year. But there's a lot of things that go on in between those visits, and that includes possibly a certified home health agency for a specific period of care for a skilled need. And it may be that we involved home health aides if the patient has some mechanism to pay for them, either Medicaid or private pay. And we may advocate for them to have a certain number of hours or increase their hours to keep them more safe at home. In addition to these kinds of services, things like hospital at home or community paramedicine may be times where acute care in the home is appropriate. And again, that's episodic, but it can help the patient in an acute need and help either shorten or avoid hospitalization. Okay. We also may involve palliative care at home, either through our own program or through an associated program, to really help with symptom assessment and treatment, and to clarify advanced directives and give support to caregiver. And if appropriate, a referral to hospice. Some take-home points. So as you can see, home care includes a wide range of services. In order to access those services, patients should be homebound and have a skilled need to receive home health care. Access to other forms of care may vary depending on geography, insurance coverage, and finances. And the standard of care of home-based primary care programs include having an interdisciplinary team, having 24-hour access to providers, and regular team meetings to review cases. Some important resources. The American Academy of Home Care Medicine has a great website And if people are interested, joining the Academy is a great way to join with colleagues to advocate for this kind of care, as well as to learn from each other and to get best practices. Likewise, the Home Centered Care Institute provides a lot of ongoing training, either webinars or recorded lectures that are extremely helpful for programs that are trying to start or to enhance their care. And then always your local geriatric and family medicine training programs often have a very acute interest in home care because it's part of their training requirements. And home care is an incredibly rewarding aspect of geriatrics and other parts of primary care. And it's an amazing insight to our patients and their resilience and their caregivers and their care network. I want to thank you for your attention. And if you have any questions, please don't hesitate to contact me at my email. Thank you so much.